Now let us learn about pyelonephritis. So what is pyelonephritis? Pyelonephritis itis is an inflammation. So it's a inflammatory disease of a kidney affecting the tubules and the interstitium as well as the renal pelvis. Mainly it's a tubulointerstitial inflammation. Okay na? It can be acute and chronic. Acute mainly caused by the bacterial infection and it is usually associated with UTI. In chronic, it's a complex disorder. Okay, the bacterial infection also plays a dominant role. Mainly, it is due to the vesico-urethral reflex or obstruction. Okay, and obstruction. Coming to the pathogenesis, more than 85% of a pyelonephritis is caused by ಯಾವುದು gram negative organism like E. coli, proteasis, Klebsiella, Enterobacter. Immunocompromised ಅಲ್ಲಿ like polyomavirus, cytomegalovirus, then adenovirus ಕೂಡ cause ಮಾಡುತ್ತೆ ಎಲ್ಲಿ immunocompromised ಅಲ್ಲಿ. Coming to the root, there are two roots, okay na, ascending root and descending root, okay na. ಸೊ ಡಿಸೆಂಡಿಂಗ್ನ ಏನನ್ಬೋದು ಎಮೆಟೋಜಿನಸ್ ಅಂತಲೂ ಅನ್ಬೋದು. ಸೊ ಎಮೆಟೋಜಿನಸಲ್ಲಿ ಏನಾಗುತ್ತೆ, ಇಟ್ ಈಸ್ ಡ್ಯೂ ಟು ದ ಸೆಪ್ಟಿಸೀಮಿಯಾ ಎಂಬೋಲೈ ಫ್ರಮ್ ಎಂಡೋಕಾರ್ಡೈಟಿಸ್, ಇನ್ಫೆಕ್ಟಿವ್ ಎಂಡೋಕಾರ್ಡೈಟಿಸ್ ಆ ಥರ. ಇಟ್ ಈಸ್ ಲೆಸ್ ಕಾಮನ್. ಮೋಸ್ಟ್ ಕಾಮನ್ ಯಾವುದು, ಅಸೆಂಡಿಂಗ್ ಪೈಲೋನೆಫ್ರೈಟಿಸ್. ಸೊ ಇಟ್ ಈಸ್ ಮೋಸ್ಟ್ ಕಾಮನ್ and it is an endogenous infection, means a patient's own fecal flora is the infectory material here. So let us see the steps how it takes place. So in the ascending pyelonephritis, first there will be colonization of distal urethra. Okay now, we'll write here. So first the bacteria will come and colonize here. Then how it reaches the bladder? Next thing is infection of bladder. How either in a female because of the short urethra, hormonal changes, or trauma to the urethra during sexual intercourse. So it can reach to the bladder, or it can reach the bladder by also by catheterization. Okay na. So then in bladder what it causes? It causes infections, right? So usually normally what happens, urine will flush out the organism, right? But whenever there is a obstruction or the urinary stasis, so like obstruction or urinary stasis in case of a BPH or calculi or neurogenic bladder, what happens, there will be the growth of organism in the bladder also. So now how it will ascend? Now next step is here ascending into the ureter. So how it ascends is through the vesico-urethral reflex. Normally what happens, the ureter is oblique and it is long, okay. So the intravesical part of ureter is a oblique and the long. Whenever the bladder contracts, basically it will cause the closure of a ureter lumen, okay na, so that urine will not backflow. But here in this vesico-urethral reflex, either ureter may be a straight or there is absent or a short intravesical ureter. So this lead to the vesico-urethral reflex which can be congenital or acquired. Now what happened, now the infection reached the ureter. Then how it will reach the ureter, from the ureter how it will reach the kidney? It is by the intrarenal reflex which occurs at the poles. Why mainly the poles? Because the calyces at the poles are the concave, so it can easily spread, okay na. Then it lead to the infection of a kidney, okay na. So coming to the morphology of acute pyelonephritis, usually it can be unilateral or it can be bilateral. The size can be a normal or it can be enlarged alva. So ಏನಾಗಿರುತ್ತೆ ಇಲ್ಲಿ ನೋಡ್ಬೋದು, it is focal discrete raised yellowish abscess ಅನ್ಬೋದು. So focal discrete yellowish raised abscess is one thing, and usually upper and the lower poles are commonly affected. I told you because their calyces are the concave. Then coming to the pelvic and calyces, there will be hyperemic, means there will be reddish. Then there will be covered by purulent exudate, because bacteria ಎಲ್ಲ ಹಂಗೆ ಹಂಗೆ ಟ್ರಾವೆಲ್ ಮಾಡ್ತಿರ್ತಾನೆ ವೈಯ ಕ್ಯಾಲಿಸಸ್ ಆ್ಯಂಡ್ ಪೆಲ್ವಿಸ್ ಫಸ್ಟ್ ದೆನ್ ಕ್ಯಾಲಿಸಸ್. ಸೊ ಅದು ಹೆಂಗೆ ರಿಯಾಕ್ಟ್ ಮಾಡುತ್ತೆ, ಹೈಪರೆಮಿಕ್ ಆ್ಯಂಡ್ ದೇ ವಿಲ್ ಬಿ ಎಕ್ಸಿಡೇಟ್, purulent exudate. Then coming to the microscopy. Microscopy, mainly pyelonephritis, it's a tubulointerstitial disease. So you will write the changes in tubule as well as interstitium. The glomuli will be normal and blood vessels will be normal, right? So coming to the interstitium. Interstitium alli enagutte, definitely there will be inflammation, neutrophilic infiltration. Because it's acute, you are going to mention it as neutrophilic. Okay na? Then what happens other than in neutrophilic infiltration, what is one more thing is your patchy, there will be patchy suppurative inflammation in interstitium. Okay na? So there will be patchy suppurative inflammation. Okay na? The next thing is here in tubules, there will be injury to the tubules. Because why? Because there will be what again, neutrophilic infiltration into the tubules, there will be injury to the tubules. Okay na? Same thing. So in interstitium ಏನರುತ್ತೆ, infiltration and your inflammation, suppurative inflammation means there is a formation of pus. There will be patchy suppurative inflammation. In tubules also same thing, glomeruli and blood vessels normal. So very important question is complication of pyelonephritis, complication of acute pyelonephritis mainly. So what happens, 3P, nenpicoli, pyelo P and 3P. One is your papillary necrosis. What happened, it is mainly seen in a diabetes, urinary tract obstruction and sickle cell anemia patient. It may be bilateral, usually it is bilateral. Okay, papillary necrosis, it is bilateral. What happens on a cut surface, tip or distal two-third of a renal pyramid will undergo yellow necrosis. In microscopy you can see necrosis. Then next one is, next P is pyonephrosis. Is nothing but accumulation of a pus within the renal pelvis and calyces and the ureter. Next thing here, what happens here, the renal capsule will break, it causes spread to the perinephric abscess. Okay, perinephric abscess. Okay na? So there will be papillary necrosis, pyonephrosis and perinephric abscess. Then coming to the clinical feature, which is sudden, there will be, it is acute pyelonephritis, so there will be sudden onset of a pain at the costo-vertebral angle and systemic evidence like fever, chills, sweat. Then features indicative of a bladder and the urethral irritation, and symptoms like dysuria frequency. What are the symptoms of a bladder and urethral irritation? Adag enagutte, dysuria, frequency, urgency, etc. So unique findings ಅಲ್ಲಿ ಏನಿರುತ್ತೆ pyelonephritic ಅಲ್ಲಿ, mainly the pus cells, right? Microscopy ಅಲ್ಲಿ pus cells ಆಗಿರ್ಬೋದು, WBC cast ಇರ್ಬೋದು, then culture and sensitivity ಮಾಡ್ಬೋದು. Coming to the chronic pyelonephritis and renal reflex nephropathy. Okay, what is chronic? Chronic is basically same thing, it's a interstitial inflammation which is associated with a grossly seeing scarring of a tissue as well as a deformity of a pelvic-calcial system, like calyxal system. So what happened, there will be, you can see the scarring, you can see the scarring of a tissue, see. So these are the scarring of a tissues, right? It is inflammation, interstitial inflammation associated with scarring of tissue as well as a deformity of a pelvic-calcial system. So what are the types? So we have two types, very important. In chronic pyelonephritis there is two types. One is reflex nephropathy or chronic reflex associated with pyelonephritis. Very important, reflex nephropathy ಅಂದ್ರೆ ಏನು ಬರಬೇಕು, ಇದನ್ನು ಬರಬೇಕು. ಓಕೆನಾ? ಯಾನು chronic ಇದು ಒಂದು type, reflex nephropathy. Another one is obstructive, chronic obstructive pyelonephritis. Okay na? So in reflex nephropathy alli enagutte, there will be congenital vesiculourethral reflex and intrauterine reflex. So it can be unilateral or bilateral. Obstructive alli enagutte, so whenever there is obstruction, definitely there is increased risk of chances of infection. So urine ade agutte, there will be recurrent and persistent infection which lead to the inflammation, atrophy and the scarring of a tissue. Then coming to the gross, okay na. So gross usually both these are different irutte, okay. So there will be broad, okay. So there will be broad irregular depressed area of a cortical fibrosis, then cortical fibrosis, then atrophy overlying a dilated calyx. So there will be atrophy, see here, yeah. So there will be, yeah, so there will be scar associated with the typical see in reflex pyelonephritis there will be polar scars, means at the pole there will be scars, okay na. So polar scars, okay, and the associated with underlying blunted calluses, okay. So again scars caused by the reflex are usually polar, which is associated with underlying blunted calyxes. Same thing, but here scars are seen throughout. See here, it is not just limited to the poles, yadrally obstructively, okay na. So and also here blunted calluses, okay na. So this is what you are going to write here. So broad irregular depressed scar associated with underlying blunted calluses, usually it can be unilateral or bilateral, usually size due to the scar, what happened, the size is decreased, correct. So scars in reflex nephropathy alli irutte upper and lower pole, but in obstructive it is throughout, right. So calluses enagirutte, there will be blunted calluses or dilated, okay na. So papillae enagirutte will be flattened. Coming to the microscopy, so microscopy interstitium alli enagtirutte, definitely it's an inflammation, so there will be inflammation, right. So chronic inflammation. Then in case of tubules ಏನಾಗಿರುತ್ತೆ, it's a tubulo-interstitial disease. So ಏನಾಗುತ್ತೆ, ಟ್ಯೂಬ್ಯೂಲ್ಸ್ಗೆ ಪದೇ ಪದೇ ಡ್ಯಾಮೇಜ್ ಆಗಿ ಏನಾಗಿರುತ್ತೆ, atrophy ಆಗಿರುತ್ತೆ. Then there will be a dilatation. Then dilated tubules will be filled with, dilated tubules with flattened epithelium will be filled with a pink substance which we called as thyroidization. Thyroidization is nothing but it will be a glassy proteinaceous cast irutte. So pass positive, okay na, it will be pass positive. Then so will blood vessels kuda damage agirutte. So there will be end arteritis obliterans, okay, there will be end arteritis obliterans. In hypertension, Eilin's atherosclerosis. Glomeruli, periglomerular fibrosis ಆಗಿರುತ್ತೆ or sclerosis ಆಗಿರುತ್ತೆ. ಕ್ಯಾಲಿಸಸ್ ಅಲ್ಲಿ ಕ್ರಾನಿಕ್ ಇನ್ಫ್ಲಮೇಷನ್, ಏನೇನು ಹೇಳಿ. ಸೊ ಇನ್ ಟ್ಯೂಬ್ಯೂಲ್ಸ್ ಅಲ್ಲಿ ಏನಾಗಿರುತ್ತೆ, ಇಂಟರ್ಸ್ಟಿಷಮ್ ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ, ಇನ್ಫ್ಲಮೇಷನ್, ಕ್ರಾನಿಕ್ ಇನ್ಫ್ಲಮೇಷನ್. ಟ್ಯೂಬ್ಯೂಲ್ಸ್ ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ, there will be atrophy, right, atrophy. There will be dilated tubules filled with a glassy eosinophilic materials, right. So which is called as thyroidization ಅಂತ ಹೇಳ್ತಾರೆ. Then blood vessels ಅಲ್ಲಿ end arteritis obliterans ಆಗಿರುತ್ತೆ, ಓಕೆನಾ. Then glomerulus ಅಲ್ಲಿ periglomerular fibrosis or it can be sclerosis only, okay. Next is one more we have, that is your xanthogranulomatous pyelonephritis. It is a very unusual and it is a rare form, usually associated with the protease bacteria. So ಇದು ಯಾಕೆ ಇಂಪಾರ್ಟೆಂಟ್ ಅಂದರೆ, ಇನ್ ಗ್ರಾಸ್ ಇಟ್ ವಿಲ್ ಬಿ ಲಾರ್ಜ್ yellow orangish nodules which confuses with the renal cell carcinoma, okay. Microscopy, same thing, chronic inflammation. Coming to the clinical features, it may be a silent onset, unusual symptoms ಇರ್ಬೋದು, like back pain, fever, pyuria, bacteria, everything. Then in reflex ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ, it is diagnosed early because ಈ ರಿಫ್ಲೆಕ್ಸಲ್ಲಿ ಇಟ್ ಇಸ್ ಅ ಕಂಜನೈಟಲ್ ಅಲ್ವಾ. ಸೊ ಅಲ್ಲಿ ಆ ಮಕ್ಕಳಿಗೆ ಹೈಪರ್ ಟೆನ್ಷನ್ ಇರುತ್ತೆ. ಬಿಕಾಸ್ ನೀವು ನೋಡ್ಬೋದು ಆ ಬ್ಲಡ್ ವೆಸಲ್ಸ್ ಎಲ್ಲ ಏನಾಗಿರುತ್ತೆ, ಎಂಡ್ ಆರ್ಟರೈಟಿಸ್ ಆಬ್ಲಿಟರೆನ್ಸ್ ಆಗಿರುತ್ತೆ. So there will be, so the diagnose while investing the cause of hypertension in children. So due to the loss of tubular function ಏನಿರುತ್ತೆ, there will be polyuria and nocturia. So obstruction ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ, it is usually present with the features of a recurrent acute recurrent pyelonephritis ಅಲ್ಲಿ ಹೆಂಗೆ ಪ್ರೆಸೆಂಟ್ ಮಾಡುತ್ತೆ ಹಾಗೆ ಪ್ರೆಸೆಂಟ್ ಮಾಡುತ್ತೆ, ಲೈಕ್ the pain in the costovertebral plus your systemic evidences all present ಮಾಡುತ್ತೆ. ಓಕೆನಾ. So this is about pyelonephritis. So now let us start with diabetic nephropathy. ಓಕೆನಾ. ಡಯಾಬಿಟಿಕಲಿ ಕಿಡ್ನಿಗೆ ಏನಾಗುತ್ತೆ ಅಂತ ನೋಡೋಣ. ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಇನ್ ಅ ಬೋತ್ ಇನ್ಸುಲಿನ್ ಡಿಪೆಂಡೆಂಟ್, ದಟ್ ಈಸ್ ಟೈಪ್ 1 ಆ್ಯಂಡ್ ಟೈಪ್ 2 ಡಯಾಬಿಟಿಸ್. ಓಕೆನಾ. ಸೊ ಪ್ಯಾಥೋಜೆನೆಸಿಸ್ ನೋಡೋದಾದರೆ, ಸೊ diabetic glomerulosclerosis is nothing but it's a generalized diabetic microangiopathy. It's a result of the generalized diabetic microangiopathy. Then insulin deficiency, there will be insulin deficiency due to which there will be hyperglycemia as well as metabolic defects which lead to the biochemical alteration. Okay now. So first coming to the pathogenesis, so non-enzymatic glycosylation as well as the products of age means advanced glycation end products, what they stimulate the synthesis of extracellular matrix, increase reactive oxygen species and cross-linking with ECM protein. This cross-linking with collagen type 4 in glomerular basement membrane, it increases the collagen type 4 and the fibronectin, but it decreases the heparin sulfate proteoglycan. So this result in thickening of a glomerular basement membrane as well as a increased mesenchymal matrix. So what are the events? So this glycosylation products as well as the formation of advanced glycation products will lead to the stimulation of extracellular matrix. Basically which extracellular matrix, basically they causes interlinking, the cross linking of a collagen type 4 in basement membrane, they increases the thickening of a glomerular basement membrane as well as ಏನು ಮಾಡುತ್ತೆ, they increases the thickening of a glomerular basement membrane as well as they increases the mesenchymal matrix. They also increases the oxygen reactive species. Okay, now this one. Next, the hemodynamic changes will lead to the glomerular hypertrophy. Okay, now so because glomerular hypertrophy, this will cause initiation and progression of diabetic glomerulosclerosis. So really second one yadu diabetic hemodynamic changes will lead to the glomerular hypertrophy. What is hypertrophy? Hypertrophy is increase in size, correct? Glomerular hypertrophy which lead to the glomerulosclerosis. Then both one, that is your glycation products as well as your hemodynamic changes will lead to the loss of podocytes. Okay now. So next third pathway is your disturbance in the polyol pathways which lead to the glomerular cell susceptibility to the causes increased susceptibility to the oxidative stress. So what are the three things? One is your glycosylated products which result in increased ECM and increase oxygen reactive species. Then second thing is your hemodynamic changes which lead to the glomerular sclerosis, and third thing is your disturbances in polyol pathways which result in increased susceptibility to oxidative stress. Okay, then coming to the morphology. So see, diabetes can involve any component. It can involve glomerulus, tubules, interstitium as well as blood vessels. Okay, so first let us see the glomerular relation. Very important, three things happens. Okay, remember there will be thickening of a glomerular basement membrane, we already know the cause, right? So then there is a diffuse mesangial sclerosis and nodular glomerulosclerosis. So these are the three things. Okay now, so coming to the thickening of a, it will be diffuse widespread thickening of a glomerular basement membrane. Okay na, ಏನಾಗುತ್ತೆ ಇಲ್ಲಿ, It is almost all cases of diabetic nephropathy ಅಲ್ಲಿ ನೋಡ್ಬೋದು. Okay, so there will be next thing will be diffuse mesangial sclerosis ಆಗಿರುತ್ತೆ. ಓಕೆನಾ. ಸೊ ದೆನ್ ನಾಡುಲರ್ glomerular sclerosis ಇದು ಓದೋಣ. Nodular glomerular sclerosis is a pathognomic feature of a diabetes nephropathy, which is also known as intercapillary glomerular sclerosis or Kimmel-Wilson disease. Wilson lesion, right? So what is this? It's basically a nodule which is oval or spherical, often lobulated. So it's a nodules of a mesangial matrix in the mesangial core, which is situated in the periphery of a glomerulus. So this nodule is surrounded by the peripheral capillary loops, and it is a stain positive. So what is KW lesion? It's basically nodule of a mesangial matrix which is round or the oval or sphericoid, often lamellated, which is situated in the mesangial core and in the periphery of a seen in a mesangial core and situated in the periphery of a glomerulus. In nodule usually it is surrounded by the peripheral capillary loop. I'll show you the nodule later. Then another lesion in your renal thing is, one is your thickening alva. Second one mesangial sclerosis, diffuse mesangial sclerosis. Then third thing is this one only, nodular glomerular sclerosis. And fourth one is your insudative lesion. Correct na ಹೇಳಿದ್ದು. Insudative lesion includes fibrin cap and capsular lesion. What is fibrin cap? Fibrin cap is nothing but endothelium iruttala. This is your, let's think, this is your podocytes and this is your parietal cell. Okay now, so this is your capillaries. Okay, so this is your capillaries. Okay now, 1 minute. Yeah, so this is your capillaries. So when there is a subendothelial accumulation of hyaline, 1 minute, pink. Okay, subendothelial deposition of a hyaline. So this forms a fibrin cap. Okay, insudative lesion. Then what is a capsular drops? Capsular drop is a round nodule which is adherent to the Bowman's capsule, which is between your Bowman's capsule, actually you are between your visceral layer and the parietal layer of a Bowman's capsule. Okay now, so this is your capsular drop. What is this? Is your fibrin cap. Then coming to the renal vascular lesion, very important. So there will be hyaline arteriosclerosis, not heart. There will also be atherosclerosis also. What I am mentioning, hyaline is your arteriosclerosis, which affects both afferent and efferent arterioles at hilum. Then renal atherosclerosis is a macrovascular complication of diabetes. Okay now, then it produces what this causes. This first thing, your glomerular lesions and your renal vascular lesion, it causes the renal ischemia. Ischemia will lead to atrophy of a tubules as well as interstitial fibrosis. Okay na. So vascular alli enagutte lesion, one is your hyaline arteriosclerosis, another one is your atherosclerosis. So what happens, there will be decreased blood flow to the tubules. Next is your interstitium. Okay, so or next complication here, acute and chronic pyelonephritis. Okay, so and there will be necrotizing papillae. So why there is necrotizing papillae? Due to the hyaline arteriosclerosis and atherosclerosis, there is decreased blood flow to the papillae, so it causes necrotizing. Okay, then coming to the tubular region, there will be basement membrane thickening, and there will be in the cells, epithelial PCT cells, there will be
extensive deposition of vacuoles of glycogen. Because it's a diabetic state, there will be vacuoles of a glycogen, right? So this is known as Harmony-Epstein lesion. What is this? Harmony-Epstein lesion. Okay now, so it's a Harmony-Epstein lesion. Then coming to the electron microscope, there is a thickening of a thickening of a lamina denso of a glomerular basement. Nothing but it's a thickening of a glomerular basement membrane. Increase in a mesangial matrix. Then exudative lesion appears as a electron dense nodule. Electron dense nodule. Okay now. Next, what is your immunofluorescence? IgG, albumin and the fibrinogen. Repeat with me, there will be some proteins, immunoglobulins and fibrinogen. Then coming to the clinical picture, they can present to you with a non-nephrotic proteinuria or nephrotic syndrome as well as chronic renal failure. So what is the importance of a microalbuminuria? So 30 to 300 mg per mg albumin per day is your microalbuminuria. It's a first sign that it's a first sign of diabetic nephropathy. Okay, so there is another marker for diabetic nephropathy and CKD, that is your liver fatty acid binding protein, LFAP. Okay, there are, what are the list the causes of necrotizing papillae. One is here, what you learn is just now is here DM. Okay, next is your obstructive uropathy, sickle cell anemia, then analgesic nephropathy. Okay, like NSAIDs, vancomycin and all can cause necrotizing papillae. Okay, so next is your diseases affecting your tubules and interstitium. Okay, so coming to the classification of a tubular and the interstitial, so just remember, there is a, in tubules and interstitial disease, there is a acute kidney disease, tubulointerstitial disease, basically which includes, I'll show the classification later, leave this. Now let's come to the, so ಇವಾಗ ಏನು ಓದೋಣ, ಅಕ್ಯೂಟ್ ಕಿಡ್ನಿ ಇಂಜುರಿ ಓದೋಣ. ಓಕೆನಾ. ಸೊ ಅರ್ಲಿಯರ್ ಏನು ಕೇಳ್ತಿರೋ ಅಕ್ಯೂಟ್ ಕಿಡ್ನಿ ಫೇಲಿಯರ್ ಅಂತ ಹೇಳ್ತಿರೋ. ಸೊ ಇಟ್ ಈಸ್ ನಾಟ್ ಅಪ್ರೋಪ್ರಿಯೇಟ್ ಬಿಕಾಸ್ severity of the damage varies and it is not always associated with the renal failure. Okay na, so it is better called as acute kidney injury. So it's a clinico-pathologic entity, very important. So in nodabodu, clinically it is characterized clinically by rapid over few days to few weeks reduction of a renal function, that is decreased EFR and excretory function. So there is a rapid decrease in a renal function. Okay na. So ಏನೇನಾಗುತ್ತೆ, function decrease ಆದರೆ there will be increase uremia and increase creatinine in serum. So severity may range from asymptomatic ಕೂಡ ಇರ್ಬೋದು or rapidly fatal ಕೂಡ ಇರ್ಬೋದು. So it's not a disease, it consists of a heterogeneous group of a condition, like there will be acute increase in serum creatinine and blood urea nitrogen and decreased volume of urea, that is nothing but oliguria or decreased output of urine output, as well as increase in a blood serum and the urea levels. Okay na. So this is a acute kidney failure. So what is acute kidney injury? Usually earlier it was known as acute kidney failure, but it's a clinico-pathological entity which is characterized by rapid decline in a renal function. Then etiology and pathophysiology. Most common cause for acute kidney injury is here acute tubular necrosis or ischemia. Okay na. Next is your pre-renal. Most common is acute tubular necrosis. Okay na. Coming to the causes of acute kidney injury. Okay na. We can divide into pre-renal cause. Pre-renal cause ಅಂದ್ರೆ ಏನಿರುತ್ತೆ? So decreased ಡಿಕ್ರೀಸ್ ಫ್ಲೂಯಿಡ್ ವಾಲ್ಯೂಮ್ ಆಗುತ್ತೆ, ಆರ್ ಡಿಕ್ರೀಸ್ ರೀನಲ್ ಪರ್ಫ್ಯೂಷನ್, ಡಿಕ್ರೀಸ್ GFR, ಸೊ ದೇ ವಿಲ್ ಬಿ ಆಲಿಗ್ಯೂರಿಯಾ, ಇನ್ಕ್ರೀಸ್ ಕ್ರಿಯಾಟಿನ್ಯೂರಿಯಾ ಎಕ್ಸೆಟ್ರಾ. ಸೊ ಐದರ್ ಏನೇನಿರ್ಬೋದು ಪ್ರೀ ರೀನಲಲ್ಲಿ, ಎಫೆಕ್ಟಿವ್ ಆರ್ಟಿರಿಯೋಲರ್ ಬ್ಲಡ್ ವಾಲ್ಯೂಮೇ ಡಿಕ್ರೀಸ್ ಆಗ್ಬೋದು, ಆರ್ ರೀನಲ್ ವ್ಯಾಸೋ ಕನ್ಸ್ಟ್ರಕ್ಷನ್ ಆಗಿರ್ಬೋದು, ಆರ್ ರೀನಲ್ ಆರ್ಟ್ರಿ ಆಬ್ಲಿಟರೇಷನ್ ಆಗಿರ್ಬೋದು. 3 ಥಿಂಗ್ಸ್, ಓಕೆನಾ. ನೆಕ್ಸ್ಟ್ ಇಂಟ್ರಾ ರೀನಲ್ ಕಿಡ್ನಿ ಒಳಗಡೆ ಏನಾಗಿರ್ಬೋದು, ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಗ್ಲಾಮುಲಾರ್ ಇಂಜುರಿ, ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಟ್ಯೂಬುಲಾರ್ ಇಂಜುರಿ. ಗ್ಲಾಮುಲಾರ್ ಇಂಜುರಿಯಲ್ಲಿ ಏನಾಗುತ್ತೆ, ದೇ ವಿಲ್ ಬಿ ಥಿಕ್ಕನಿಂಗ್ ಆಫ್ ಅ ಬೇಸ್ಮೆಂಟ್ ಮೆಂಬ್ರೇನ್, ಸೊ ದೇ ವಿಲ್ ಬಿ ಡಿಕ್ರೀಸ್ GFR. ಟ್ಯೂಬುಲಾರ್ ಇಂಜುರಿಯಲ್ಲಿ ಏನಾಗುತ್ತೆ, ಕ್ಯಾಸ್ಟ್ ಎಲ್ಲ ಬರುತ್ತೆ, ಸೊ ದೇ ವಿಲ್ ಬಿ ಡಿಕ್ರೀಸ್ GFR, ಓಕೆನಾ. ದೆನ್ ಪೋಸ್ಟ್ ರೀನಲ್ನಲ್ಲಿ ಆಗಿರ್ಬೋದು, ಡ್ಯೂ ಟು ದ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಅದು ಏನಾಗಿರುತ್ತೆ, ಬ್ಯಾಕ್ ಫ್ಲೋ ಆಫ್ ಅ ಇನ್ಕ್ರೀಸ್ ಬ್ಯಾಕ್ ಫ್ಲೋ ಆಫ್ ಅ ಯೂರಿನ್, ಡಿಕ್ರೀಸ್ GFR, ಓಕೆನಾ. ಸೊ ಕಮಿಂಗ್ ಟು ದ ಈಗ ನೋಡೋಣ ಕಾಸಸ್ ನೋಡೋಣ ಪ್ರೀ ರೀನಲ್ದೆಲ್ಲ. ಸೊ ನಾವು ಗೊತ್ತಾಯಿತು ಪ್ರೀ ರೀನಲ್ 3 ಥಿಂಗ್ಸ್ ಆಗಿರ್ಬೋದು, ಐದು ಡಿಕ್ರೀಸ್ ಎಫೆಕ್ಟಿವ್ ರೀನಲ್ ಬ್ಲಡ್ ಫ್ಲೋ ಆಗಿರ್ಬೋದು, ಆರ್ ದೆರ್ ಮೇ ಬಿ ಅ ರೀನಲ್ ವ್ಯಾಸೋಕನ್ಸ್ಟ್ರಕ್ಷನ್ ಆರ್ ಯರ್ ರೀನಲ್ ಆರ್ಟ್ರಿ ಆಬ್ಲಿಟ್ರೇಷನ್. ಕಮಿಂಗ್ ಟು ಯರ್ ಲೈಕ್ ಏನೇನು ಕಾಸ್ ಆಗಿರ್ಬೋದು. ಸೊ ಡಿಕ್ರೀಸ್ ಎಫೆಕ್ಟಿವ್ ಆರ್ಟೀರಿಯಲ್ ಬ್ಲಡ್ ವಾಲ್ಯೂಮ್, ಓಕೆ. ಇಟ್ ವೇಸ್ ಅ ಕಾರ್ಡಿಯೋರೀನಲ್ ಸಿಂಡ್ರೋಮ್, ದಟ್ ಈಸ್ ನಥಿಂಗ್ ಬಟ್ ಇನ್ ಕೇಸ್ ಆಫ್ ಹಾರ್ಟ್ ಫೇಲಿಯರ್, ರೈಟ್. ಸೊ ಲೆಫ್ಟ್ ಹಾರ್ಟ್ ಫೇಲಿಯರ್ ಆದಾಗ ಏನಾಗುತ್ತೆ, ಕಾರ್ಡಿಯಾಕ್ ಔಟ್ಪುಟ್ ಡಿಕ್ರೀಸ್ ಆಗುತ್ತೆ, ಸೊ ದೇ ವಿಲ್ ಬಿ ಡಿಕ್ರೀಸ್ ಬ್ಲಡ್ ಫ್ಲೋ ಟು ದ ಕಿಡ್ನಿ. ಆರ್ ಯುವರ್ ರೈಟ್ ಹಾರ್ಟ್ ಫೇಲಿಯರ್ ಆದಾಗೂ ಕೂಡ ಆಗುತ್ತೆ, ಯಾಕೆ ಅಂದರೆ ಇಟ್ ಇನ್ಕ್ರೀಸಸ್ ಸೆಂಟ್ರಲ್ ವೀನಸ್ ಪ್ರೆಷರ್ ವಿಚ್ ಕಾಸಸ್ ರೀನಲ್ ವೀನಸ್ ಕಂಜೆಷನ್. ಹೇಳಿ, ಇನ್ಕ್ರೀಸ್ ಸೆಂಟ್ರಲ್ ವೀನಸ್ ಪ್ರೆಷರ್ ಆಗುತ್ತಾ, ರೀನಲ್ ಕಂಜೆಷನ್ ಆಗುತ್ತೆ. ದೆನ್ ಎಪಿಟೋರೀನಲ್ ಸಿಂಡ್ರೋಮ್, ಸೊ ಹಾರ್ಟ್ ಆಯಿತು, ನೆಕ್ಸ್ಟ್ ಲಿವರ್. ಸೊ ಇಲ್ಲೇನಾಗುತ್ತೆ, ಇನ್ ಕೇಸ್ ಆಫ್ ಡಿಕಂಪನ್ಸೇಟೆಡ್ ಸಿರೋಸಿಸ್ ಆಲ್ಬುಮಿನ್ ಎಲ್ಲ ಕಡಿಮೆ ಇರುತ್ತೆ. ಆಲ್ಬುಮಿನ್ ಕಡಿಮೆ ಇದೆ ಏನಾಗುತ್ತೆ, ಆಂಕೋಟಿಕ್ ಪ್ರೆಷರ್ ಕಡಿಮೆ ಇದೆ. ಆಂಕೋಟಿಕ್ ಪ್ರೆಷರ್ ಕಡಿಮೆ ಇದ್ದರೆ ಏನಾಗುತ್ತೆ, ದೇ ವಿಲ್ ಬಿ ಡಿಕ್ರೀಸ್ ಎಫೆಕ್ಟಿವ್ ಆರ್ಟೀರಿಯಲ್ ಬ್ಲಡ್ ವಾಲ್ಯೂಮ್. ಸೊ ಇನ್ನೊಂದು ಕೂಡ ಲೈಕ್ ಇನ್ನೊಂದು ಮೆಕ್ಯಾನಿಸಮ್ ಲೀಡ್ಸ್ ಟು ದ ಡಿಕ್ರೀಸ್ ಆರ್ಟೀರಿಯಲ್ ಬ್ಲಡ್ ವಾಲ್ಯೂಮ್ ಯಾವುದು ಅಂದರೆ ಯುವರ್ ಪೋರ್ಟಲ್ ಹೈಪರ್ಟೆನ್ಷನ್ ಆಗಿರುತ್ತೆ. ಸೊ ಅದರಿಂದ ಏನಾಗುತ್ತೆ, ಸೊ ಅದನ್ನ ರಿಲೀವ್ ಮಾಡೋಕ್ಕೆ ಹೋಗ್ತಾರೆ. ಸೊ ರಿಲೀವ್ ಮಾಡೋಕ್ಕೆ ಏನಾಗುತ್ತೆ, ಲಿವರ್ ಆ್ಯಂಡ್ ಎಂಡೋಥೀಲಿಯಲ್ ದೇ ರಿಲೀಸಸ್ ದ ವ್ಯಾಸೋಡೈಲೇಟರ್ಸ್, ಬಟ್ it enters the systemic circulation and causes splanchnic vasodilation. So it will causes decrease effective arterial blood volume, and also decrease effective arterial blood volume. Then coming to the hypovolemia conditions, correct? Hypovolemia like diarrhea, diuresis, dehydration, blood loss. Then hypotension condition like any kind of a shock, okay. So what are the 4 things we can write? So your heart causes, liver causes, then your hypovolemia causes, then your shock where there will be circulatory failure, right? Septic shock, cardiogenic shock, everything. Then next thing here, renal vasoconstriction. So afferent ಕನ್ಸ್ಟ್ರಿಕ್ಟ್ ಆಗಬೇಕು, ಎಫರೆಂಟ್ ಡೈಲೇಟ್ ಆಗಬೇಕು, ಆವಾಗ GFR ಕಡಿಮೆ ಆಗುತ್ತೆ, ಕರೆಕ್ಟಾ. ಅಫರೆಂಟ್ ಯಾವುದೇ ಇದು ಮಾಡುತ್ತೆ, ಎನಸೈಡ್ಸ್ ಆ್ಯಂಡ್ ಟೋಕ್ರೋಲಿಮಸ್, ಓಕೆನಾ. ಎಫರೆಂಟ್ ಯಾವುದೇ ಡೈಲೇಟ್ ಮಾಡುತ್ತೆ, ACE ಇನ್ಹಿಬಿಟರ್ ARBs. ನೆಕ್ಸ್ಟ್ ರೀನಲ್ ಆರ್ಟ್ರಿ ಆಬ್ಲಿಟ್ರೇಷನ್ ಯಾವಾಗುತ್ತೆ, ಅಥಿರೋಸ್ಕ್ಲಿರೋಸಿಸ್ more than 50 years, fibromuscular disease less than 50 years, ಓಕೆನಾ. ದೆನ್ ಕಾಸಸ್ ಆಫ್ ಇಂಟ್ರಾರೀನಲ್ ಬನ್ನಿ. ಇಂಟ್ರಾರೀನಲಲ್ಲಿ ಟ್ಯೂಬುಲಾರ್ ಇಂಜುರಿ ಆದರೆ ಐ ಟೋಲ್ಡ್ ಯು ಟ್ಯೂಬುಲಾರ್ ಇಂಜುರಿ ಆ್ಯಂಡ್ ಗ್ಲಾಮುಲಾರ್ ಇಂಜುರಿ. ಟ್ಯೂಬುಲಾರ್ ಇಂಜುರಿ ಎಲ್ಲೆಲ್ಲಾಗುತ್ತೆ, ಸೊ ಇನ್ ಕೇಸ್ ಆಫ್ ATN, ದಟ್ ಈಸ್ ಅಕ್ಯೂಟ್ ಟ್ಯೂಬುಲಾರ್ ನೆಕ್ರೋಸಿಸ್. ಅಕ್ಯೂಟ್ ಟ್ಯೂಬುಲಾರ್ ನೆಕ್ರೋಸಿಸ್ನ ಹೆಂಗೆ ಡಿವೈಡ್ ಮಾಡ್ಬೋದು, ಇಶ್ಕೆಮಿಕ್ ಆ್ಯಂಡ್ ಟಾಕ್ಸಿಕ್. ಇದನ್ನ ಆಮೇಲೆ ಓದೋಣ ನಾವು, ಓಕೆ. ಇಶ್ಕೆಮಿಕಲ್ಲಿ ಏನೇನಾಗುತ್ತೆ, ಸೊ ದೇರ್ ಇಸ್ ಡಿಕ್ರೀಸ್ ರೀನಲ್ ಪರ್ಫ್ಯೂಷನ್, ಸೊ ದೇರ್ ವಿಲ್ ಬಿ ಡ್ಯಾಮೇಜ್, ರೈಟ್. We'll read this mechanism later, okay. So decrease renal perfusion. Nephrotoxic ಅಲ್ಲಿ ಏನಾಗಿರುತ್ತೆ, the drugs. What are the causes of nephrotoxic acute tubular necrosis? There can be drugs, pigments, crystal, IG. At least broad ಥಿಂಗ್ಸ್ನ ಕಳ್ಕೊಂಡೆ ನಾವು ಒಳಗಡೆ ಏನೋ ಹಾಕ್ಬೋದು ಅಲ್ವಾ. ಸೊ ಡ್ರಗ್ಸಲ್ಲಿ ಯಾವುದ್ಯಾವುದು, ವ್ಯಾಂಕೋಮೈಸಿನ್,
Aminoglycans, very important here, contrast dye, amphotericin. Okay, 2A, remember 2A, aminoglycosides, amphotericin, and your favorite vancomycin. And what is another one? Your contrast dye. Okay, now then pigments ಅಲ್ಲಿ ಯಾವುದು hemoglobin ಮತ್ತು myoglobin. Crystals ಅಲ್ಲಿ mainly the uric acid. Then IG ಅಲ್ಲಿ Benz Jones protein, multiple myeloma. Okay na. Drugs, pigments, then drug, pigments, crystals and IG. So drugs ಅಲ್ಲಿ ಅಂದರೆ 2A, aminoglycoside, amphotericin, vancomycin, then your contrast dye. Then your drugs ಆದಮೇಲೆ pigments ಅಲ್ಲಿ hemoglobin, myoglobin. Then your crystals ali uric acid. Then this here is your IG, multiple myeloma. Correct. Next, acute intestinal nephritis. So idu tubular. Okay na, idu interstitial. So interstitial nephritis ali mainly the medication like NSAIDs, beta lactams, PPIs, etc. Okay na. Next is your tubular injury. Tubular injury ali, so it can be a glomerular nephritis, right? Glomerular nephritis basically mainly is your ANCA vasculitis and anti-glomerular basement membrane disease. ANCA vasculitis, anti-glomerular basement disease, lupus nephritis. Okay na. Then there is a even rapidly proliferating progressive glomerular nephritis. Then thrombotic microangiopathy like DIC, HUS and TTP. So glomerular nephritis and so thrombotic microangiopathy which include DIC, HUS, TTP. Then causes of post-renal basically obstruction. Okay. So complications ಏನೇನಿರುತ್ತೆ? ಮೆಟಬಾಲಿಕ್ acidosis. So metabolic acidosis ಆದಾಗ ಏನು ಪ್ರೆಸೆಂಟ್ ಮಾಡ್ತಾರೆ? So there will be increased respiratory rate, right? Tachypnea, then hyperkalemia, then your vasodilation. ಆ ಟೈಮ್ಗೆ ಯಾಕೆ ಮಾಡುತ್ತೆ? It causes serious effects, vasodilation and decrease cardiac output. It causes decreased BP. So metabolic acidosis ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ? There is increased respiratory rate, hyperkalemia and his vasodilation, cardiac output decrease. Then hyperkalemia ಆಗ್ಬೋದು, then hyperolemia, ವಾಲ್ಯೂಮಿಯಾ, ಬಿಕಾಸ್ ಇಲ್ಲಿ ಫ್ಲೂಯಿಡ್ಸ್ ಎಲ್ಲ ಹೊರಗಡೆ ಹೋಗ್ತಿಲ್ಲ, ಒಳಗಡೆಯಿಂದ ಉಳ್ಕೋತಿದೆ. ಸೊ ದೇ ವಿಲ್ ಬಿ hypervolemia state, like it leads to the pulmonary edema, pleural effusion, pedal edema and increased BP. ಓಕೆನಾ. ಸೊ ಏನೇನಾಗುತ್ತೆ? ಪಲ್ಮನರಿ ಎಡಿಮಾ, ಪ್ಲೂರಲ್ ಎಫ್ಯೂಷನ್, pedal edema, increased BP. Then uremia, very important. So we can see uremic encephalitis, hyperuremic pericarditis, hyperuremic pneumonia something, right? So it causes encephalopathy which leads to confusion, asterix, nausea, vomiting, pericarditis which result in chest pain, pleural rub effusion. Then even it can cause platelet dysfunction which inhibits the degranulation, which causes bleeding. Okay, so what are the complications? First is your metabolic acidosis, the second is your hyperkalemia, and third is your hypervolemia, and fourth is your, what is the main thing, very important, uremia. This can lead to the encephalopathy, pericarditis as well as platelet dysfunction. Okay, now next come to the, see, this is important. See, tubulointestinal disease you can classify it into ischemic or toxic injury, which can be called as acute tubular injury or necrosis. Then inflammation, it is a tubulointestinal nephritis. It can be infection idre pyelonephritis. If it is toxins, it can be by a physical obstruction, neoplasm. It
can be by a immune like sarcoidosis, transplant rejection ಎಲ್ಲ. Main thing now let us learn about acute tubular injury or necrosis. Very important. Even this is a most common cause for your acute kidney injury. Very important. Okay na. So it is a clinical pathological entity. So there will be acute renal failure plus or minus evidence of injury to the tubules. So they can be even plus or minus morphological evidence of injury to the tubules. It's a most common cause for acute kidney injury. Okay. Acute tubular acute tubular injury. It is a most common cause for acute kidney injury. Okay. So acute tubular injury, it can be ischemic or toxic. Okay na. So ischemically all the pre-renal causes, right? So decreased blood volume or micro involvement of a renal blood vessel like microscopic polyangiitis, HUS, TTP. Then toxic. So toxically endogenous, we already list the causes, right? So it can be your it can be your pigments, main thing your drugs, it can be your crystals, right? It can be your, what is another thing, your hemoglobin. We already know this. Okay now, next. So why the renal tubules are prone to the injury? Because they are involved in a active transport, right? So they are having a very high rate of metabolism. They have a very high oxygen demand, so they are easily susceptible to injury. Okay now, 1 minute. Yeah. So what is the pathogenesis of acute tubular injury? How it will get injury? So whenever there is ischemia, so this lead to the sublethal endothelial injury. Okay. So sublethal endothelial injury. So endothelial will release definitely endothelin whenever there is injury. Correct? So this endothelin causes vasoconstriction. So vasoconstriction reduce GFR, oliguria. Okay na. So this is your ischemia. Basically there is an involvement of a endothelial injury. That's all. So coming to the toxins, what they'll do is, so they causes tubular epithelial injury. It can be in 2 ways. Either it is reversible or irreversible. So let us see first reversible. So reversible enagutte, there will be redistribution of membrane proteins. Okay. Innonsati heli. So membrane proteins ಎಲ್ಲ redistribute ಆಗಿರುತ್ತೆ. There will be loss of polarity. So there will be abnormal ion transport. ಸೊ ಇದರಿಂದ ಸೋಡಿಯಂ ಇಲ್ಲಿ ಪ್ರಾಕ್ಸಿಮಲ್ ಟೇಬಲಲ್ಲಿ ಎಲ್ಲ ಮೋಸ್ಟ್ ಆಫ್ ದೆಮ್ ಅಬ್ಸರ್ವ್ ಆಗಬೇಕು. ಬಟ್ ಇಲ್ಲೇನಾಗುತ್ತೆ, ಇನ್ಕ್ರೀಸ್ ಸೋಡಿಯಂ ಟು ದ ಡಿ ಸಿ ಟಿಗೆ ಹೋಗುತ್ತೆ. ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ, ಟ್ಯೂಬುಲೋ ಗ್ಲೋಮುಲರ್ ಫೀಡ್ಬ್ಯಾಕ್ನ ಆಪರೇಟ್ ಮಾಡಿ ದೇ ಸ್ಟಿಮ್ಯುಲೇಟ್ ದ ರಾ ಸಿಸ್ಟಮ್. ಸೊ ಹೇಳ್ತೀರಾ, ಸೊ ರಿವರ್ಸಿಬಲ್ ಏನಾಗುತ್ತೆ, ಸೊ ದೆ ವಿಲ್ ಬಿ ರೀಡಿಸ್ಟ್ರಿಬ್ಯೂಷನ್ ಆಫ್ ಮೆಂಬ್ರೇನ್ ಪ್ರೋಟೀನ್ಸ್ ಮೆಂಬ್ರೇನ್, ಆ ಸೆಲ್ ಒಳಗಡೆ ಇರೋ ಮೆಂಬ್ರೇನ್ ಪ್ರೋಟೀನ್ಸ್ ಎಲ್ಲ ಲೈಕ್ ಅರೇಂಜ್ಮೆಂಟ್ ಚೇಂಜ್ ಆಗುತ್ತೆ. ದಿಸ್ ಲೀಡ್ ಟು ದ ಲಾಸ್ ಆಫ್ ಪೊಲಾರಿಟಿ. ಸೊ ದಿಸ್ ಲೀಡ್ ಟು ದ ಅಬ್ನಾರ್ಮಲ್ ಅಯಾನ್ transport. This lead to the increase sodium to the distal tubule, which activates tubuloglomerular feedback, which stimulates RAS. Then another thing, so this reversibility, there can be a detachment of a cell which causes tubule obstruction, which increases intratubular pressure. Definitely back pressure increase again ಆಗುತ್ತೆ, GFR ಕಡಿಮೆ ಆಗುತ್ತೆ. ಓಕೆನಾ. So what happened, there will be detachment of cells leading to the tubular obstruction, decreased GFR. Then irreversible ಏನಾಗುತ್ತೆ, ಸತ್ತೋಗುತ್ತೆ cells ಎಲ್ಲ. So ಸತ್ತೋಗುತ್ತೆ. So there will be what, same thing, tubular obstruction, intratubular pressure, reduced GFR. Correct? So another thing, tubular back leakage ಆಗುತ್ತೆ, decreased tubular flow. Same thing. So tubular backflow ಆದಾಗ ಏನಾಗುತ್ತೆ, there will be interstitial edema, increase interstitial pressure, which lead to the further damage of tubules, again decreased GFR.
ಸೊ ಅಲ್ಟಿಮೇಟ್ಲಿ ದೆರ್ ಇಸ್ ಡಿಕ್ರೀಸ್ ಜಿ ಎಫ್ ಆರ್ ಆಯಿತಾ. ಸೊ ಇರಿವರ್ಸಿಬಲ್ ಏನಾಗುತ್ತೆ, ಡೆತ್ ಆಫ್ ಅ ಸೆಲ್ ಆಗುತ್ತೆ. ಡೆತ್ ಆಫ್ ಅ ಸೆಲ್ ಆದಮೇಲೆ ಏನಾಗುತ್ತೆ, ಸೊ ದೆ ವಿಲ್ ಬಿ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್, ಓಕೆನಾ. ಇನ್ನೊಂದು ಟ್ಯೂಬುಲರ್ ಬ್ಯಾಕ್ ಲೀಕ್, ಲೈಕ್ ಇನ್ನೊಂದು ಏನಾಗುತ್ತೆ, ಟ್ಯೂಬುಲರ್ ಬ್ಲ್ಯಾಕ್ ಲೀಕ್ ಆಗಿ ದೇ ಡಿಕ್ರೀಸಸ್ ಟ್ಯೂಬುಲರ್ ಬ್ಲ್ಯಾಕ್ ಫ್ಲೋ. ಇನ್ನೊಂದೇನು, ಇಂಟರ್ಸ್ಟಿಷಿಯಲ್ ಎಡಿಮಾ. even the tubular these they release cytokines, even those can cause injury to the tubules, okay na. Next morphology bandre there will be ischemic type bandre, so there will be swollen tail cortex, congested medulla, okay na. So microscopy, so glomulus appears normal, so it's a tubular, what we are reading is acute tubular necrosis. So we'll mainly focus on tubules, okay na. Tubules ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ ಅಂದರೆ areas of a tubules involved, so will be focal and multiple areas of a damage, large skip areas, okay, most mark, okay, yeah. So areas of in ischemic type ಏನಿರುತ್ತೆ, so there will be focal and multiple areas of a damage, okay. Skip areas ಇರುತ್ತೆ, ಲೈಕ್ ಇಲ್ಲಿ ಡ್ಯಾಮೇಜ್ ಆಯಿತು, ಇಲ್ಲಾಗಿಲ್ಲ, ಇಲ್ಲಾಗುತ್ತೆ. ಸೊ ದೆ ವಿಲ್ ಬಿ ಲಾರ್ಜ್ ಸ್ಕಿಪ್ ಏರಿಯಾಸ್ ಆ್ಯಂಡ್ ದೆ ವಿಲ್ ಬಿ ಫೋಕಲ್, ಇಟ್ಸ್ ನಾಟ್ ದ ಡಿಫ್ಯೂಸ್ ಒನ್, ಇಟ್ಸ್ ಅ ಫೋಕಲ್ ಮಲ್ಟಿಪಲ್ ಏರಿಯಾಸ್ ಆಫ್ ಅ ಡ್ಯಾಮೇಜ್, ಲಾರ್ಜ್ ಸ್ಕಿಪ್ ಏರಿಯಾಸ್, ಓಕೆನಾ. ಸೊ ದೆರ್ ಇಸ್ ಅ ಡ್ಯಾಮೇಜ್ ಟು ದ ಟ್ಯೂಬಿಲ್, ಓಕೆನಾ. ನೆಕ್ಸ್ಟ್ ಟ್ಯೂಬುಲರ್ ಎಪಿಥೀಲಿಯಲ್ ಆಲ್ಟ್ರೇಷನ್. ಈಗ ಎಪಿಥೀಲಿಯಲ್ ಏನೇನಾಗುತ್ತೆ ನೋಡೋಣ. ಎಪಿಥೀಲಿಯಲ್ ಸಿಂಪ್ಲಿಫಿಕೇಷನ್, ಜಸ್ಟ್ ದೆ ವಿಲ್ ಬಿ ಫೋಕಲ್ ಫ್ಲಾಟ್ನಿಂಗ್ ಆ್ಯಂಡ್ ಲಾಸ್ ಆಫ್ ಬ್ರಷ್ ಬಾರ್ಡರ್ ಎಲ್ಲ ಕಿತ್ತೋಗುತ್ತೆ. ದೆನ್ ಬ್ಲಬ್ಬಿಂಗ್ ಆ್ಯಂಡ್ ಸ್ಲಾಜಿಂಗ್ ಆಫ್ ಅ ಬ್ರಷ್ ಬಾರ್ಡರ್ಸ್, ವಿ ಆಲ್ರೆಡಿ ನೋ, ಕರೆಕ್ಟ್ ಅಟ್ಯಾಚ್ಮೆಂಟ್ ಆಫ್ ಸೆಲ್. ಸೊ ದೆ ವಿಲ್ ಬಿ ಬ್ಲಬ್ಬಿಂಗ್ ಆ್ಯಂಡ್ ಸ್ಲಾಜಿಂಗ್ ಆಫ್ ಅ ಬ್ರಷ್ ಬಾರ್ಡರ್. ಫಸ್ಟ್ ಏನಾಗುತ್ತೆ, ಸುಮ್ಮನೆ ಆಗೋಗುತ್ತೆ, ಎಲ್ಲ ಡ್ಯಾಮೇಜ್ ಆಗೋದ್ರಿಂದ ಫ್ಲ್ಯಾಟ್ ಆಗಿ ಮಲ್ಕೊಬಿಡುತ್ತೆ, ಫೋಕಲ್ ಫ್ಲ್ಯಾಟನಿಂಗ್ ಆ್ಯಂಡ್ ದೆ ವಿಲ್ ಬಿ ಲಾಸ್ ಆಫ್ ಅ ಬ್ಲಷ್ ಬಾರ್ಡರ್. ಸೊ ಅದಾದಮೇಲೆ ಬ್ಲಬ್ಬಿಂಗ್ ಆ್ಯಂಡ್ ಸ್ಲಾಜಿಂಗ್ ಆಫ್ ಅ ಬ್ಲಷ್ ಬಾರ್ಡರ್ಸ್. ದೆನ್ ದೇರ್ ವಿಲ್ ಬಿ ಅ ಪ್ರೋಟೀನೇಷಿಯಸ್ ಕ್ಯಾಸ್ಟ್. ವಾಟ್ ಹ್ಯಾಪನ್, ಸ್ಲಾಜ್ಡ್ ಅಪೈಕಲ್ ಸೈಟೋಪ್ಲಾಸಮ್ ಏನಿರುತ್ತಲ್ಲ ಅದು ಪ್ಲಸ್ ನಾನ್ ನೆಕ್ರೋಟಿಕ್ ಪ್ರಾಡಕ್ಟ್ಸ್ ಪ್ಲಸ್ ನೆಕ್ರೋಟಿಕ್ ಪ್ರಾಡಕ್ಟ್ಸ್ will lead to the hyaline cast and the brown pigmented granular cast seen in the lumen of distal tubule, collecting duct and the urine. So ಏನಾಗುತ್ತೆ, there will be proteinaceous cast, okay na, hyaline cast as well as brown pigmented granular cast. What are the cast? Either full pink irbodu or brown pigmented cast. Then which is composed of TAM asphalt protein. We'll read that later. Then there will be occlusion of a lumen which lead to the dilatation. So ಏನಾಗುತ್ತೆ, dilatation ಆಗುತ್ತೆ, focal flattening of a epithelium ಆಗಿರುತ್ತೆ. Then there will be loss of a brush border, then blubbing and sloughing, okay, slodging of a brush border. Then there will be proteinaceous cast. Then there can also be a rupture of a basement membrane which lead to the tuberosity and epithelial regeneration. Then interstitial ಏನಾಗುತ್ತೆ, there will be edema, we already know, right, edema and inflammation. Then blood vessels ಏನಿರುತ್ತೆ, ನಾರ್ಮಲ್ ಇರುತ್ತೆ. ದೆನ್ ನೆಫ್ರೋಟಾಕ್ಸಿಕ್ ಅಲ್ಲಿ ಏನಾಗಿರುತ್ತೆ ಅಂದರೆ ಮೇನ್ಲಿ ಇಟ್ ಇನ್ವಾಲ್ವ್ಸ್ PCT more extensively. It is limited to certain segments which are more sensitive to the toxin. Mainly your hemoglobin cast irutte, right? So they will produce red brown tubular cast, not the hyaline cast, okay na. Okay. TAM Hertzfeld protein. What is TAM Hertzfeld protein? We'll see that later. First, let us understand what is cast. Cast is nothing but it's a protein meshwork with entrapped cells and cell fragments. ಏನದು, ಅದೊಂದು meshwork, protein meshwork with the entrapment of cells and the cell fragments. So cells in the ascending thick, okay na, this is ascending ascending thick loop of Henle and DCT. So they secrete, okay, DCT, thick ascending loop of Henle, they secretes a small amount of glycoprotein called term Earth's-wall protein, which forms a meshwork that entraps the cells in the tubule to form a cast. It's basically cells in the ascending loop of Henle as well as your DCT. They produce a glycoprotein. They produce and secrete the glycoprotein, small amount of glycoprotein, which is known as term Earth's-wall protein, which form a protein meshwork to which that enhances cells in a tubules to form cast. Then what is the clinical feature of acute tubular neck injury? Okay, so usually we have a stages like initial stage, maintenance stage and recovery stage. In initial stage there is decreased urinary output, increased blood urea nitrogen, increased serum creatinine. It is seen up to 36 hours. Then maintenance phase, there is sustained decrease in urine output, oliguria, salt and overload, hyperkalemia, metabolic acidosis. See your complications of your acute renal injury is coming, right? So what a complication: hyperkalemia, metabolic acidosis, uremia, etc. Okay. Next, in recovery phase, there is steady increase in urine output, which may reach up to 3 liters per day, right? There will be loss of a large amount of water, sodium and potassium in the urine. So it's a prognosis, it's a reversible condition. Now coming to the last topic for today's, that is your chronic kidney disease. Okay na? So yesterday salpane ide, okay na? Okay. CKD, very important. It's a broad term used to describe the final common pathway of a progressive nephron loss resulting from any type of severe kidney disease. So what they are telling is, it's a broad term which describe that it's a pathway, it's a final common pathway of a nephron loss, progressive nephron loss, which is resulting from any of a type of a kidney disease. Okay, then it's usually, so it's a broad term that it describes the final common pathway of a progressive nephron loss resulting from any of the cause of a severe kidney disease, any type of a severe kidney disease. So it's a progressive and it's an irreversible state. Okay, CKD is a progressive irreversible. It is treated with a dialysis or transplantation. What are the causes of CKD? Okay, we divided here also. It can be glomerulopathies, where, so what is PGN? Okay, we'll read that later. So crescentic glomerulonephritis, membrane proliferative glomerulonephritis, IgA nephropathy, everything. Okay. Then systemic is your DM, SLE, amyloidosis, polyarthritis nodosa gout, etc. In interstitial, so chronic interstitial nephritis, chronic pyelonephritis, analgesic, TB, everything. Then obstructive, it can be calculus tumors or retroperitoneal fibrosis. Then renovascular, it can be essential hypertension or vasculitis. Congenital, it can be adult polycystic kidney disease and medullary cystic disease. Okay, na? So what are the causes of a CKD? It can be anything. It can be glomerulopathies, it can be tubulointerstitial, it can be a systemic disease, it can be a obstructive, it can be a vascular disease also, it can be a congenital also. Then coming to the pathogenesis, so what happens here in this is, there is a progressive loss of nephrons, okay, and there is a two mechanism to destroy neuron. Okay, so basically there is a progressive loss of nephrons. Why? Initiating mechanism, it depends on the underlying etiology. what is your initiating. Okay, later there will be adaptive mechanism, right? They try to maintain homeostasis. What happened, how they try to maintain homeostasis is they glomerular hyperfiltration in the ಪಾಪ ಬದುಕಿರುತ್ತಲ್ಲ ನೆಫ್ರಾನ್ಸು, ಆ ನೆಫ್ರಾನ್ಸಿಗೆ ಜಾಸ್ತಿ ಫಿಲ್ಟ್ರೇಷನ್, ಗ್ಲೋಮುಲರ್ hyperfiltration in the surviving nephrons and increase rate of excretion of solute per nephron. ಸೊ ಅದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, ಸೊ ಆ ನೆಫ್ರಾನ್ ಚೆನ್ನಾಗಿ ಮಾಡಿ ಇನ್ಕ್ರೀಸ್ ರೇಟ್ ಆಫ್ ಎಕ್ಸ್ಕ್ರೀಷನ್ ಆಫ್ ಸೊಲ್ಯೂಟ್ per nephron. It happens through increased plasma concentration for, so it happens through ಏನಾಗಿರುತ್ತೆ, whenever there is increased plasma concentration of creatinine ಜಾಸ್ತಿ ಆದಾಗ, or there is decreased reabsorption of sodium, correct, phosphate or calcium, or there is increased tubular secretion of potassium and potassium and H plus ion. It happens through these things. 1 minute. Coming to the pathogenesis of CKD. So first ಏನಾಗಿರುತ್ತೆ, there will be progressive, basically there is a progressive loss of nephrons, right? So it occurs under the two mechanism, right? So what happens, there will be initiating mechanism. It depends on the underlying etiology, and there will be adaptive mechanism. So the kidneys were so good, they try to maintain homeostasis by giving a extra amount of work to the surviving nephrons, that they causes glomerular hyperfiltration in surviving nephrons, and they also causes them to excrete, they increases the rate of excrete of a solute per nephron. How they increases the solute excretion to, they decreases the reabsorption of sodium, phosphate and calcium. So they are increasing solute, okay na? So they also causes secretions of potassium and hydrogen ion, okay na? Then whenever there is increase creatinine in the plasma, so there will be more creatine available for filtration, there will be even creatine excretion, okay na? So yeah, so in gross, how we can see is here, okay, so in gross, how you see, there will be symmetrically contracted kidney, very important. Outer surface will be your red brown diffusely granular, chotu so a small regular fine granular. So your symmetric contracted kidney, and outer surface your red brown diffusely granular, which is granular is small, regular and the fine granular. Coming to the microscopy, so in glomerulus there will be scarring glomeruli. So scarring of the glomeruli, common to all is your advanced clouding of a very common is your scarring of a glomeruli, okay. The obliteration of a glomeruli is the end point of many disease, and it is not possible to determine the nature of a lesions. So gotaita, so there will be scarring of a glomeruli oitu, then atrophy and dropouts of the tubules, then interstitial fibrosis and inflammation, then thickening of wall, blood vessels ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ, thickening of a wall with a narrowing lumen. So thickened wall with a narrow lumen, okay na? So what are the features of a chronic CKD? There will be scarring of a glomeruli, atrophy of a tubules as well as a dropout of a tubule, interstitial fibrosis and inflammation, thickening of a wall with a narrowing lumen of blood vessels. So clinical features, is insidious in onset. It is often asymptomatic. It manifests only as biochemical abnormalities like proteinuria, hypertension and azotemia, okay. It is slowly progressive disease, okay na? Initially most of them are asymptomatic, ಅವ್ರಿಗೆ ಗೊತ್ತಿರಲ್ಲ, but it is frequently suspected when they have proteinuria, hypertension or azotemia during their routine medical examination. What is azotemia? Azotemia is a biochemical abnormality which is characterized by two things: elevation of your
blood urea nitrogen as well as creatine levels. It is mainly due to the decreased GFR. Okay, no? Then laboratory urea findings. So in physical examination, so there will be fixed specific gravity around 1.010. It is a isosthenuria. Okay, now so there will be specific gravity is fixed. Next, because there is no function, there is no changing of a concentration, everything, right? Chemical examination, hematuria, proteinuria, glycosuria means with the normal blood glucose. Okay, 1 minute. Glycosuria with normal blood glucose level is common in your chronic kidney failure. Then coming to your microscopy of a urine, the cells will be your WBCs, right? Which 1 minute. So cells in the urine usually white. If it is a WBCs are present, then it indicates the bacterial urinary infection or sterile pyuria. So sterile pyuria, it is seen in your papillary necrosis as well as a renal tuberculosis. Okay, now WBCL consider in your bacterial infections and sterile bacterial infections and sterile pyuria el ನೋಡ್ತೀರಾ in case of papillary necrosis and tuberculosis, renal tuberculosis. Then if it is eosinophilic, then it is allergic. Then in RBC, it can be anywhere in the, you can see like if anywhere damage between the urinary tract, in the urinary tract between the glomerulus and the urine meatus. Okay, na? So RBC cast el ನೋಡ್ತೀರಾ glomerular nephritis. Granular cast el ನೋಡ್ತೀರಾ active renal ಡಿಸೀಸ್ ಅಲ್ಲಿ ಗ್ರಾನ್ಯುಲರ್ ಕಾಸ್ಟ್ ಇರುತ್ತೆ. ಬ್ರಾಡ್ ಕಾಸ್ಟ್, ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್ ವರ್ಡ್, ಬ್ರಾಡ್ ಕಾಸ್ಟ್ is seen in chronic renal failure. Okay, na? So a urine culture should be performed and early morning urine sample should be culture for tuberculosis. Without treatment, prognosis is very poor for CKD. Then what are the complications? Very important question, complications. So anemia of a chronic disease, metabolic bone disease like renal osteodystrophy, so which lead to the hyperparathyroid bone disorder and your osteomalacia, osteoporosis, etc. Okay, na? Which what are the metabolic bone disease it includes? It includes hyperparathyroid bone disease, which is also known as osteitis fibrosa cystica, osteomalacia and osteoporosis. Then in GI, there is reduced gastric emptying and increased risk of reflex esophagitis, increased risk of peptic ulcer, constipation and GI bleeding. ಹೇಳ್ತೀರಾ? ಸೊ ಫಸ್ಟ್ ಒನ್ ಏನು ಅನಿಮಿಯಾ ಆಫ್ ಕ್ರಾನಿಕ್ ಡಿಸೀಸ್, ಸೆಕೆಂಡ್ ಒನ್ ಏನು ಮೆಟಬಾಲಿಕ್ ಬೋನ್ ಡಿಸೀಸ್. ಅದರಲ್ಲಿ ಯಾವ್ದು ಇರುತ್ತೆ? ಹೈಪರ್ ಪ್ಯಾರಾಥೈರಾಯ್ಡ್ ಬೋನ್ ಡಿಸೀಸ್, ಆಸ್ಟೋಮಲೇಷಿಯಾ ಆ್ಯಂಡ್ ಆಸ್ಟಿಯೋಪೊರೋಸಿಸ್. ಥರ್ಡ್ ಒಂದು ಏನಿರುತ್ತೆ ಇವಾಗ ಜಿ ಐ ಏನೇನಾಗುತ್ತೆ ಪೇಷಂಟ್ಗೆ? ಆ ಪೇಷಂಟ್ಗೆ ಸ್ಲೋ ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಎಂಪ್ಟಿಂಗ್ ಇರುತ್ತೆ. there will be increased reflex of esophagitis and there will be risk of peptic ulcer ಇರುತ್ತೆ, ಕಾನ್ಸ್ಟಿಪೇಷನ್ ಇರುತ್ತೆ, GI bleeding ಆಗ್ಬೋದು. Then metabolic abnormalities like in gout, insulin resistance and lipid abnormalities like increase triglyceride and hypercholesterolemia. So metabolic abnormalities like gout, so uric acid ಹೋಗಲ್ಲ, ಸೊ ಗೌಟ್ ಇರುತ್ತೆ, ಇನ್ಸುಲಿನ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಆ್ಯಂಡ್ ಹೈಪರ್ ಕೊಲೆಸ್ಟ್ರಾಲಿಮಿಯಾ. ಎಂಡೋಕ್ರೈನ್ ಅಬ್ನಾರ್ಮಲಿಟೀಸ್ ಲೈಕ್ hyperprolactinemia, increased luteinizing hormone in both of the sexes, then decrease serum testosterone levels. Okay, then absence of a normal cyclical changes in female sex hormones, so they will be resulting in oligomenorrhea or hemenorrhea, abnormality of growth hormone secretion and secretion and action, abnormal thyroid levels. So many things, it affects many things, right? So it affects the hyperprolactinemia, increased growth hormone, decreased testosterone, and the it can cause oligomenorrhea, it can cause thyroid abnormalities, right? So many things. Then it can cause proximal myopathy. Then nervous system, it can cause medial nerve compression in a carpal tunnel disease due to the beta 2 microglobulin related amyloidosis. Why there is a beta 2 microglobulin related amyloidosis? Because of the dialysis. Okay, they can compress the median nerve, so it can cause carpal tunnel syndrome. So then there can be a serious diseases like MI, cardiac failure, sudden cardiac death, stroke, pericarditis, everything. There can be a malignancy. There will be increased incidence of malignancy. Okay, so what are, let us revise once again. So what are the complication? Anemia of a chronic disease, then metabolic bone disease, 3 things: parathyroid bone disease, osteomalacia or osteoporosis, then metabolic abnormalities like your gout, insulin resistance, then hypercholesterolemia, then your endocrine. What is endocrine? Hyperprolactinemia, hyper LH, right? So then abnormal growth hormone secretion, then your oligomenorrhea or amenorrhea. Then in males it causes decreased testosterone, then abnormal thyroid function. Then in GI it can cause increased peptic ulcer, decreased gastric empty, and increased risk of reflux esophagitis, constipation and bleeding. In case of nervous system, it can cause compression of a median nerve due to the beta 2 macroglobulin related to dialysis. In case of a serious, many complication, MI, sudden death, sudden cardiac death, cardiac failure, pericarditis, etc. So many things. Then even it increases the risk of malignancy, and there is another one is proximal myopathy. Okay, thank you.